Lenny, thoughts on radium-223?
Yeah, I think radium-223 is going to be another paradigm shift. The curious thing about the alpha-radon, as it's known, is that it was not originally looked at to extend survival. It was really looked at more of a palliative drug. And in the very early studies of alpha-radon, they noted that there would seem to be a survival advantage, and that completely shifted the emphasis of the clinical trials into an overall treatment for metastatic prostate cancer. So as opposed to our traditional radiopharmaceutical agents like strontium or samarium that are beta emitters, there was a lot of toxicity associated with those agents because they had a very long penetration. And as you alluded to, the alpha particle in the radium-223 has a very short extent of its effect, and therefore, since we get most of our metastasis in the bone and not in the marrow, its marrow suppression is very limited. It can cause some marrow suppression, but nothing to the degree of the beta emitters. So the Alsimca trial looked at patients who were either intolerant or not eligible for docetaxel chemotherapy, and randomized them to placebo versus the active agent, and they received infusions once every month for 6 months. And actually, it was able to show about almost a little bit more than a 3.5 to 4 month survival advantage. And this is an overall survival advantage using the drug.
Well, this patient actually ended up getting, being put on abiraterone and Zytiga. We all know it's four capsules in the morning taken on an empty stomach. You do need 5 milligrams of prednisone BID, and actually has done very nicely up until this point. So anyway, so this last portion, we'll spend a little bit of time talking, which again, as I think we've sort of alluded to this during the course of this conversation, is moving forward in the future. What's the best way to manage the castration-resistant prostate cancer? I mean, these are very challenging patients, and what's even more challenging is that is the number of therapies, all with different mechanisms of action. No real trials out there, studies, very difficult to do that regards sequencing. Lenny, as you so appropriately pointed out, is that we do not have a surrogate marker that we can fall back on that might allow us to conduct these trials in a more efficient fashion in order to predict overall survival. So the question is, this has always been, and I think, Mark, you alluded to this earlier, historically, when we only had docetaxel, the urologists were always accused of hanging on to these patients too long and really sending them over to the medical oncologist when they PSAs were sky high and multiple Mets. And again, I think it's the fact that for a lot of reasons, many of these patients, when they develop metastatic disease, Evan, as you pointed out, a lot of times they're asymptomatic. We never just, we weren't looking for them.
Almost all the time they're asymptomatic.
Right.
They just didn't get out that way.
And when we did see them or find them, probably incidentally, the patients really weren't that fired up about going over there. I think the urology world, we probably didn't do a good job of emphasizing how poorly these patients were doing with a very limited median survival. So again, I think we're all morphing to this multidisciplinary approach. I know that in the academic world, which is really, it's done very well, you probably have multidisciplinary conferences. You get the medical oncologist, the radiation oncologist, supportive care, the whole team approach. On the community side, Larry, both of you really have cancer centers, centers of excellence. What are you guys doing to sort of mimic what's being done in a very nice fashion by our academic colleagues?
Well, what we've done at the Urology Center of Colorado is we have an advanced prostate cancer panel. And it's kind of an extension of our tumor board that we have incorporated within our center. And it's a multidisciplinary clinic or panel so that we get our radiation oncologist, our medical oncologist, the urologists, we have our nurses, our physical therapists. We even bring our billers to this meeting so that we can figure out if these patients are going to get approval for the kind of recommendations that we make.
Did you say billers or bankers?
So we're the bankers, we have the billers. So, but we really believe that it's a multidisciplinary approach to things, and we're trying to offer the best treatments and make the best decisions for our patients, and we think that's the way to do it in our setting.
I think a venue like this is fantastic. Historically, our practice has grown through word of mouth and patient awareness that there are alternatives. Through the, urologists build up a long-term relationship with their patients, and as Evan pointed out, this is often, even when it's metastatic, an asymptomatic disease, and historically the treatments had a lot of toxicity, minimal change in overall survival. Now we've got a complete paradigm shift where we've got effective treatments that clearly prolong survival without destroying quality of life at the same time. So now there's a motivation to find this earlier and get on the bandwagon to treat these patients, and they're going to live. We talk about these intervals of survival advantage being short, but now you've got 3, 4, 5 different things. And I personally believe that when you get these treatments in earlier, you get even more bang for the buck, longer prolongation of survival. Some people debate that, but I think that it does indeed make a difference.
Lenny, Evan, any last thoughts? Because we're about to wrap up here. It's been a great exchange.
I think the challenge that we're going to face, as we've all mentioned, is the sequencing of these agents. I think this is going to really occupy a lot of our discussions in the next 3 to 5 years, figuring out the optimum way to bring these drugs into patients. And for the urology audience, this again is a shift in our practice. Medical oncologists are used to calling in for approval for these drugs. We're used to calling in approval for our surgical scheduling and not for the drugs. So urologists who are interested, as the drugs are moved earlier, need to change office staff policies and procedures for getting pre-approval for these new drugs that are out there. So there's going to be a lot of moving things going on right now. And again, educating people about the drugs and the different mechanisms of actions as they're coming along so quickly. I think particularly the new residents who are now in training as these drugs are coming out are going to become much more comfortable with them and bring these out into their academic and community settings as they go forward.
Evan?
I think the key is teamwork. I think with these new drugs, especially these less toxic drugs, there's more we can do. There's more we can do and we should do them early. And I think the newer age, the younger age urologist is very used to and comfortable working in a multidisciplinary fashion with radiation, with medical oncology. I think it's happening now. I think it's only going to continue to happen more in the future. I think we just have to foster that environment.
I just wanted to add one more thing that we always try to do is to try to get patients into our clinical trials, and I think that's a very important aspect. I mean, it gives them an opportunity to get a treatment that they can't get any other way, and it also will help promote the entire field in trying to get some of these new therapies approved and delivered to patients in the future.
Yeah, and I agree completely, and I think the thing to realize is all these new therapies, we wouldn't have them today if it wasn't for the patients that went on clinical trials. So we have to thank all those people, and we have to continue to encourage that.
Absolutely. Mark, final thoughts?
I'm just seconding the thoughts that have been shared, the idea of early diagnosis rather than letting the disease get out of control, combined with these new agents. I see it's a real revolution, and it's going to continue to happen with more things coming soon.
Well, gentlemen, great. I appreciate the time you've spent. I think it's been a great discussion. So on behalf of our panel, I want to thank you for joining us and hope you found this peer exchange to be very informative and hopefully will allow you to go out and manage your castration-resistant prostate cancer patients better in a more informed and evidence-based fashion. So thank you for joining us.